Hello to all my hardworking, bright, nervous, and probably exhausted students. These are all the emotions that the students go through as the INI-CET exam is nearing. We are a little bit anxious. We are a little bit nervous. Some of us think that we have forgotten everything that we have studied. Some of us are self-doubting ourselves. But all these are emotions which are raw and pure, and which I also had, which you also have, and which the coming generations every time, every attempt will also have. Nervous energy is probably good energy. It pushes you forward to give your best and to excel in the attempt of the INI-CET exam that is coming forward. I am Dr. Utsav Bansal, Ophthalmology faculty at Marrow, and this is the discussion of recall questions INI-CET November 23. Now, as all of us know that the closer we move to the exam, the more focus is on remembering or understanding or reading the recent topics which are getting asked. We want to know the trend of the exam. We want to get into the mind of the examiner. And this is what we are trying to do through this recall series, as we have done previously in all recall series. So in INI-CET November 23, 5 questions were asked from ophthalmology, and it was a surprise that all the 5 questions were pretty straightforward and pretty easy. There was no ectopic question from ophthalmology, which is generally the case. So what was the distribution of the questions out of the total 5 questions? As you can see, there were 2 questions which were image-based, and the other 3 questions were purely theoretical questions. 2 questions came from optics, one was from cornea, one was from orbit, and one was from retina. When we will see them further, we will notice that the question on optics and on cornea both, these 3 questions were clinical questions. And when I say clinical questions, I don't need to say clinical scenario questions. All I'm trying to say was that these questions pertained to the fact that you are a doctor. So they were investigation based questions. So they were scenario based questions which you would encounter each and every day in your OPD. The question from orbit and retina, that was straightforward, a theoretical question. So these were the 5 questions, fairly well distributed and fairly the trend. All right. Now let us start with the first question. The first question was a question which I have spoken a lot of times since the past 5 years, that these are the most important questions from optics. These are the most important questions. I have explained them in depth and you will see why. Very simple question if you have read this topic. A child went to an ophthalmologist and is found to have a power of -1 diopter spherical and -2 diopter cylindrical, and the cylindrical power has been prescribed at 180 degrees. Straightforward question. What kind of astigmatism does the child have? All right. So basically, the child would have been complaining of loss of vision, and the doctor has prescribed a spectacle, which, if I want, I can simplify as -1 diopter sphere along with -2 diopter cylinder at 180. So people who know this topic, let us do very quickly. First of all, sphere and cylindrical both are given and both are given as minus. Yes, that means it's myopic. So first of all, I will search for myopic. But as I see in the option, there is nothing given as myopic astigmatism or hyperastigmatism. So they are not bothered about the myopic or the hypermetropic part. Okay. So then I see it is minus at 180 degree. So that means what they are asking me, they're asking me, number one, whether it is simple astigmatism or compound astigmatism. Number two, whether it is with the rule astigmatism or against the rule astigmatism. Simple astigmatism. Simple astigmatism means only cylinder. Am I right, guys? Am I right, guys? Yes. So that means this is ruled out because there is spherical as well as there is cylindrical. So it is compound astigmatism. This much I know. What kind of compound is it? Both minus. So it is compound myopic astigmatism. Can it be mixed astigmatism? Option number D. No, it cannot be. Because in mixed astigmatism, there is minus sphere with plus cylinder, or there has to be plus sphere with minus cylindrical. So this is also ruled out. That means the simple question is what the examiners actually want to ask you, whether it is with the rule astigmatism or whether it is against the rule astigmatism. So we know at 180 degree minus has been prescribed. Minus means concave. Now if we remember the magic with CV against VC, if we do remember this, then the answer is pretty clear that this is which astigmatism? This is with the rule astigmatism. which clearly means it is with the rule astigmatism. The answer is pretty clear for me. So, with the rule astigmatism. But as I've always said, that this is an important point. You should know how to read a spectacle prescription. Yes, that is the topic where this question is from. So let us revise first of all astigmatism. Astigmatism, as we should remember, is of two types. One is called with the rule, and the second is called as against the rule. What is the meaning of with the rule? With the rule means when vertical is more curved. Vertical meridian or vertical curvature is more curved. Very easy to remember. VW, Volkswagen, or alphabets. PQRSTUVW. And against the rule. Against the rule means obviously horizontal is more curved. When we think about it, when we put our mind to it, we get this table. What is the table? With CV against VC. Yes. So this is the $1,000,000 table, which I have always said, please try to remember it is a mnemonic, guys, with CV against VC. You have a beautiful CV. You have an impressive CV. You are the best possible CV. So again, with your good CV, you are going against the vice chairman of the hospital. Yes. So this is the mnemonic. This is the story behind this mnemonic, with CV against VC. If I remember this, all I had to do was in the question that has been asked, I had to look at 180 degree. I looked at 180 degree. Then I looked at the fact that it was minus power given. Minus power means concave. So when concave lens is prescribed at 180 degree, the answer is with the rule astigmatism. That is all I had to do. Yes. Am I clear about this? Yes. You can solve any question on the type of astigmatism with the rule or against the rule just with this simple 2 by 2 table. If you don't know this topic at all, then let me go simpler. Then let me give you examples like I always give. If a power has been prescribed which is minus and which is spherical. Spherical means only two refractor errors, myopia and hypermetropia, and minus means myopia. M for myopia, M for power more, M for chashma, minus or spectacles minus. Plus spherical means hypermetropia, yes. Minus cylinder, myopic cylinder, but only cylinder. If it is only cylinder, it will be, yes, guys, very good. Simple myopic astigmatism. Plus cylinder, simple hypermetropic astigmatism. Minus sphere, minus cylinder, just like we have done in the current example in the question, compound myopic astigmatism. Plus sphere, plus cylinder, compound hypermetropic astigmatism. Are you getting my point? Minus is myopic, plus is hypermetropic. It is as simple as that. If it is only a cylinder, it is simple. If it is cylinder as well as sphere, it is compound. But what about the last? The last example tells us minus with plus or plus with minus. Yes, this becomes a case of mixed astigmatism. But what is the secondary rule here? What is the secondary rule of mastication? Yes, very good. The secondary rule is that the cylindrical power should always be greater than spherical power. All right. Without that, mixed astigmatism rule does not apply. I hope we are pretty clear. This is a quick revision on how to read spectacle prescription. The answer to the question, both are minus. So this is compound myopic astigmatism. And because minus has been given at 180 degree, minus given at 180 degree, our answer becomes with the rule. And that is the complete answer to our question. It should have been a pretty simple question had you read this. And you should have read this. This is a screenshot from our main videos, guys. If you can see example number 10 here, this is the same kind of example. Minus with minus, okay? It's just given at 90 degree. 90 degree was ATR or against the rule. The table, the same table that I have just now told you has also been made in the main videos. So I've been telling this point again and again. I will again tell this point. Prescription of glasses, how to read prescription of glasses, how to prescribe glasses, the tests for vision, all these are very, very, very important parts of ophthalmology. Half our OPD is made from the fact that patients want correction. whether correction removal in form of surgeries for spectacles or in the form of prescription for spectacles. So that is why they are a very important clinical aspect of ophthalmology, and that is where the exam is headed. So please, please, please do focus on this. When you will see the past 5-year questions, whether from NEET or from INI-CET, you will see at least 6th or 7th time such a question has come from the same topic. I'm not saying the same question, but from a similar topic. All right, guys, done. Let us move on to the second question that was asked in INI-CET, an image-based question, a very easy question. Again, a direct question from our main videos and our notes. If we had read it, let us see. An image has been given. All of us can see the image. The question is identify the filter, the dye used, and the condition. So the question is like pretty easy, because once they are asking you the filter and once they are asking you the dye, you can actually see the color. So what kind of light do we see falling? Can you see? It is a blue colored light. As soon as I can see a blue color light, option A and option D get ruled out. Because option A says cobalt green, option D says cobalt green. The light is not green, the light is blue. All of us can see the beam of light, which is blue in color, cobalt blue light or cobalt blue filter of light. Now, the second part, which dye is it? Is it fluorescent dye or is it lissamine green dye? So if you had never read this topic, then I can understand the confusion. But if you have ever read this topic even once, if you have seen photographs, then you know it is which dye. Yes, it is fluorescent dye. And the answer becomes option B. If you have never read this topic, please remember some basic points about fluorescent dye. Fluorescent dye. What is the color of fluorescent dye? Fluorescent dye is orange in color. Then cobalt blue illumination or cobalt blue filter light illumination is done. Why is it known as fluorescent? Fluorescent name has been given because this dye has a property of fluorescence. Fluorescence means when light falls, it changes color and shines with a different color. Yes. So it fluoresces in green color. That is the basic of fluorescent dye. If you have ever read it once, please understand this. This was the question. What was the light? The light was cobalt blue. Yes. Then what was the shining? The shining was green color. All right, guys. If you had seen the main videos, you can again see the screenshot attached here. I hope it will be pretty easy for you. This is the same thing I have taught, that orange colored dye. This is the orange colored dye. You can see this is a strip with an orange colored dye impregnated on it, which we are staining the eye or the cornea. Then there is a cobalt blue light to illuminate, and after that it is visible as green fluorescence. Same straight question as has been taught to you, no rocket science. And why are we using fluorescent dye? If we don't know that, then please see the uses of fluorescent dye. First of all, it is used in corneal ulcer. In corneal ulcer, it stains denuded epithelium. Denuded means the areas where epithelium is broken. And by staining the denuded epithelium, it is staining the base of ulcer. Yes. If we remember, there are two things in an ulcer, base and a margin, right, guys? Yes. Secondly, the same dye, the fluorescent dye, is used in Goldman's applanation tonometry. Goldman's applanation tonometry is the gold standard for tonometry, that is IOP measurement. We stain it, then we see two Myers. We adjust the position of the Myers with the inner margins just touching each other. Third use, it can be used to diagnose dry eye by measuring tear film height meniscus. And lastly, it can be used to perform a test which is called as Siddle's test. Siddle's test is performed to evaluate any perforation. If there is any perforation in the eye, assume it. If I have all pin and through an all pin, my cornea has been perforated. When I will stain my cornea, This dye will stain the aqueous because now there is a connection between the outside world and the anterior chamber. So that is called as Siddle's test. So if Siddle's test is positive, it indicates perforation. Okay. Siddle test positive indicates perforation. I hope you understand this. If you didn't know this, the earlier three you should have known. They are pretty easy uses of fluorescent dye. I hope we are pretty clear about this. Yes. Let us move back to the question. There is nothing called as cobalt green filter. Wrong. Corneal degenerations. Please read the topic. Hyaline deposits are stained with meson trichrome. Congo red. Yes, you understand all those stains. Then interstitial keratitis. It is not stained. Interstitial keratitis means inflammation only of the stroma. Lissamine green dye. Lissamine green dye stains vital tissue. Okay, it can be used to stain the cornea as well as the normal conjunctiva. It is not toxic at all to the vital tissue or to the normal tissue. Am I making myself very clear? Yes, guys, done. So pretty straightforward question on corneal ulcer and a dye out of that. Rose Bengal dye, I hope all of you know. Rose Bengal dye is pink in color. Just one more name, so just mentioning it. Rose Bengal dye is pink in color. All right, guys, done. Let's move on to the next question. The third question, which was asked in INI-CET, which was again an image-based question, which was again, how do I say it? It was a direct spot. Direct spot means I can show you the photograph, and even without knowing anything, if you have seen that once, only once, you will be able to answer it. Yes. So the following instrument is used to measure which of the following? Yes. Let me make it more difficult for you. What is the instrument, first of all? What is the instrument? If you know the name of the instrument, yes. So this is called an exophthalmometer. There are two types of exophthalmometers. This is called as Hertel's exophthalmometer, whereas this is called as Louis' exophthalmometer. Now, as soon as I'm showing you two names, both the names are using the word exophthalmometer. That means they are used to measure or diagnose exophthalmos. And this is exophthalmos. Yes. What is exophthalmos? Protrusion of the eyeball. Protrusion of the eyeball or proptosis. The answer is pretty simple here. So this was a direct spotter. There was, no understanding in this question. You should have known this question, and this is as simple as that. Apart from this, all I can say is please try to remember the types of proptosis, the causes of proptosis, orbital cellulitis, cavernous sinus thrombosis. What are the differences between them? Orbital varices and keratocavernous fistula. What are the differences between them? The vascular causes and the inflammatory causes. They are frequently asked, though not very frequent, but they are frequently asked. What we have seen in the past is a lot of questions have been asked from proptosis. But now again, we see a trend shifting towards the clinical diagnosis. They want you to know more of what you are going to actually do in your OPD, right? So the postings which you have missed, which you have ignored, those are important. If you go to your postings, this is what you do, this is what you see. And that is the direction in which the exam is moving. They want you to become doctors and not just book readers. Yes, we can't become doctors just by reading the books. I know I also became a doctor just by reading the book, but that was not a very good way of becoming a doctor, right? Now, please see the option fourth, stereopsis. Stereopsis question was asked 2 years back. Stereopsis means 3D vision, or I can say depth perception. Now, another prospective question in the future can be this image. This image is a test for which of the following? So this test is called as, yes, very good if you know this, Titmus fly test. And it is used for diagnosing stereopsis. Okay. Am I clear about this? Again, direct spotter. Moving on to the next question. Next question was a kind of a history-based question. A lot of students get anxious on reading such questions. They tend to ignore it, but please don't. This was a pretty easy question. Find the keyword in the question. That is what I'm trying to teach you. Question number 4. A man with known history of diabetes. Okay, that's the word. His vision is 6/6, normal vision. However, on retinal examination, he is classified to have severe NPDR. which is all right. A diabetes patient has non-proliferative diabetic retinopathy. Very easy here. All they are asking you now is which of the following is not a feature of this condition. They're asking you which of the following is not a feature of this condition. That means I know the other stage of this disease is PDR or proliferative. So that means the examiner will try to confound me through something which is found in proliferative. So even without reading the options, I already know what the examiner would have done. Non-proliferative means no proliferation, nothing growing. Proliferation means growing. And what grows in proliferative? What is the only sign of proliferative? Yes, guys, if you remember this, neovascularization. When new vessels grow, we call it proliferation, proliferative diabetic retinopathy. And till the time new vessels do not grow, we call it non-proliferative. That means the examiner is trying to see whether I know this fact or not. That means all I'm trying to search for in the options is this word. Let me read. Option A, retinal microvascular changes. Okay. Option B, retinal hemorrhages. Okay. Option C, disc neovascularization. I know disc neovascularization will not occur in NPDR, which will occur only in which stage? Proliferative diabetic retinopathy. All the other three things can be found in a case of non-proliferative diabetic retinopathy. Severe non-proliferative diabetic retinopathy follows the 4-2-1 rule, if we remember. Okay. 4 quadrants of hemorrhage, 2 quadrants of venous bleeding, and 1 quadrant of IRMA, intraretinal microvascular abnormalities. If any two are present, it gets classified as severe. If all are present, it gets classified as very severe. Hemorrhage means option B, venous bleeding means option D, and IRMA means option A. Okay. So either we remember this classification of what is severe NPDR, what is very severe NPDR, or we just remember the basics. What is NPDR and what is PDR? And I would have done it the first way. What is NPDR versus what is PDR? P means proliferation. Proliferation means neovascularization. As I always say, how to recognize neovascularization. This is a photograph which shows neovascularization at the disc. But how do we understand neovascularization if you don't? So when I see the blood vessels here, I see two types of blood vessels. One is this blood vessel. All these blood vessels you can see are straight and branching. If the blood vessels are straight and branching, they are normal vessels. But then I look at the second group of vessels. The second group of vessels, when I see they are forming a tuft. Can you see? One group of tuft. I will rub it. I will rub it for you guys. Now I hope you are able to see it. Group number 1, tuft of vessel. Group number 2, tuft of vessel. And a very small group of vessel. So when we see a tuft of vessels, then we know we are looking at neovessels. Neovessels are leaky vessels. Because they are leaky vessels, that is why on fundus fluorescein angiography, they are hyperfluorescent. All right, guys. So again, I'm happy that this question was asked because this is very, very, very basic and core retina, right? We should know this. All of us should have read this. They have asked you what actually is expected to be asked from you. They have not gone hi-fi on you. They have not gone to journals. They have not gone to ectopic questions. They have not gone to the depths to find questions. They are asking you what needs to be asked. And we are happy if they are asking you that. You should be happy if they are asking you that, right, guys? Done. And so the answer becomes disc neovascularization. I hope we are pretty clear. All the other signs, such as microaneurysms, hemorrhages, exudates, cotton wool spots, venous bleeding, IRMA, all these are seen in non-proliferative diabetic retinopathy, as has been asked in the question. Now, the only confusion that some students who shared this question with me had is, sir, why is the vision 6/6 even if there is NPDR? So please remember that the most common cause of loss of vision in diabetic retinopathy is cystoid macular edema. In the question, there is no mention of macular edema. They are only saying it is non-proliferative diabetic retinopathy. As I like to say, non-proliferative diabetic retinopathy is no problem. NP is no problem, right? That is why it is a stage where we ask the or where we are actually educating the patient. We are asking the patient only to follow up with us again and again. We are asking the patient to control the sugar because we know it is not a big problem. The vision is still not getting lost unless macular edema occurs. So in a lot of cases, in almost all cases that we see of NPDR without macular edema, we usually see that the vision will remain 6/6. All right, guys, done. Let's move on to the last question, which was asked in the INI-CET November 23 attempt. The only question where some of the students felt that there could have been a controversy. But I'm sorry to say, I'm sorry to inform you, it is not a controversy. It is a pretty straightforward question. Only if we are overthinking, then yes, we can get at the wrong answer. Let us read the question. A professional boxer, okay, MMA or boxing, right? Muhammad Ali, something like that, wants vision correction surgery. Very good. Which of the following is not recommended? So basically, we are saying the patient has myopia. Now the patient wants a surgical correction. Now, under surgical correction, what are the options? Option number 1. Option number 2, laser surgeries, if I can just say. Then option number 3, if I can say, will be ICL surgery. Option number 4 is Intax surgery. Okay, a revision of your surgeries for myopia. Now, once we have all these options, obviously these two options have not been given, so I will cut them. Now the question is whether a laser surgery is safer or a manual surgery. What is the full form of RK? Radial keratotomy. First of all, guys, radial keratotomy. This is a historical surgery. We don't do this now. This was popular in 70s, 80s, and a little bit in the 90s. We don't do it now. And we don't do it now. That is the question, basically. Why don't we do it? So what is radial keratotomy? Let us see through an image. In this image, what can you see on the cornea? If we look carefully, we can see a lot of radial cuts. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12 at all the clock hours. Not necessarily they have to be 12, but what is necessary is that there have to be peripheral cuts. It can be done with 4 cuts, 6 cuts, 8 cuts, 10 cuts, or 12 cuts. These are partial thickness peripheral incisions in cornea. Okay? What is the purpose of this surgery? Why are we giving these incisions? When we are giving these incisions, we are presuming that when we are giving these incisions, they will be healing and they will be stretching the central cornea. So we are trying to flatten the central cornea. When we flatten the central cornea, we decrease the power and thus we are able to treat myopia. Okay. Why is it not done? What are the drawbacks of this? The two drawbacks of this surgery are, number 1, hyperopic self-correction after some years. Meaning what? After some years, 5-7 years, the flattening starts to increase so much that instead of myopia going to 0, the power starts moving towards the hyperopic spectrum. So the patient starts developing hypermetropia instead of myopia. And the second drawback is this: perforation. When I have given, if this is my cross section of the cornea, guys, when I have given a partial thickness cut, I have given partial thickness cuts, I have made the cornea weak. And in professions such as athletes, such as boxer, where somebody punches, there is a lot of pressure on the eye. Yes, when you are punching, there is a lot of squishing and then the release of the pressure. Yes, when you apply pressure, then the pressure release is also there. Newton's law. So what will occur? Due to the thinning, due to the weakening of the cornea at the point where I had given the incision, what occurs? Perforation, as can be seen here. Can you see the cuts here again? 1, 2, 3, what are seen in the light? I'm just trying to mark them for you. Yes. And at cut number 8, you can see that the iris has prolapsed due to iris perforation. So obviously, when you are into a profession like boxing, we know your profession will encounter a lot of hits near or at the eye. So the chances of perforation will be very, very, very high. And that is why radial keratotomy will be the answer to the question, without any doubt. Please understand this. Lot of students would like to argue here, would like to contest here, sir, why not LASIK? Sir, in LASIK, it is a flap based surgery. Sir, when it is a flap based surgery, the flap can get dislocated. I understand that. I am pretty aware of that. But the flap will not get dislocated after 1 month or 2 months. The flap will completely become part of the cornea. It just needs time. It is like a wound. Yes, wounds heal. Once the wounds heal, you cannot open them again. Are you getting what I'm trying to say? So, flap based complications, flap dislocation, blah, 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 they can only occur maximum in the first 1 week or at max in the first 1 to 2 months. If we are doing a LASIK surgery in an athlete, obviously we will advise that athlete or that boxer not to do any physical activity for the next 3 to 6 months. Till that time, you will not be able to even recognize that the flap had ever been made. In a lot of cases, post 1 year of LASIK surgery, the surgeon cannot make out whether LASIK had been done or not. Obviously, it depends on the quality of the LASIK being done. So, LASIK cannot be a contraindication here. Obviously, SMILE will be a better surgery because SMILE is a flapless surgery here. I can understand that in a boxer, the SMILE will be a better surgery, but that does not mean that LASIK will be contraindicated. I'm being pretty clear here, pretty open here. Just because it is a flap-based surgery, it will not be a contraindication. It will just entail some kind of precaution after the surgery. But when we have done radial keratotomy, we have made your cornea weaker for life. After 1 year, 2 year, 5 years, whenever you do boxing, there will be pressure and the perforation will take place. The iris prolapse will take place. That is why in boxers or in professionals like boxers, radial keratotomy is not recommended or absolutely contraindicated. I hope we are pretty clear about this. I hope we understand the 5 questions, the simple questions, the important questions, the good questions that were asked in this INI-CET November 2023 attempt. As I always say, guys, keep studying hard, keep on moving forward. Whenever in doubt, take a break, think about your goal, close your eyes, and move forward again. It is good to have doubts on yourself. That tells you that you are probably moving in the right direction, that you are not overconfident. But if you are doubting yourself too much, please remember it is just an exam, it is just a competition, it is not the end of life. You will succeed. If not, if this is not your time, maybe you have something better written for yourself. Have trust in yourself. If you are working hard, everybody is seeing that and you will get the desired results. And as usual, whenever you have any problems, any doubts, feel free to contact us. For ophthalmology, please feel free to contact me. My best way to ask me any doubt is on my Instagram, and I am simply writing my ID for all of you to follow and share any of your doubts. Thank you, guys.